We have Dr. Eric Luitweiler will launch us here in the first half hour, followed by Alex Hawkins, and then Dr. Lecca will wrap up the morning in the 9 o'clock slot. And without further ado, Eric, go ahead.
Thanks so much. Can everyone hear me?
Yep, sound good.
Okay, good. Let's see. All right, and slides are showing. Okay.
Yep.
Okay, great. All right. Well, we can go ahead and get started. So hi, everyone. For my nephrology ground rounds topic, I chose alkali therapy and chronic kidney disease. So it's a very relevant topic. And despite how routine the management may seem, I've come to learn there's a lot of new and growing perspectives around this topic, and I look forward to sharing them with you. And so just to start, a review of the objectives for today. First, we'll be reviewing the physiology of how kidneys handle acid and the pathophysiology of how metabolic acidosis develops in chronic kidney disease. We'll talk more about evidence for the clinical benefit of alkali therapy in slowing progression of kidney disease. We'll look further if there's a role of alkali therapy in management of CKD in patients with normal serum bicarb, which there's been more growing discussion around. And then lastly, we'll touch on other strategies, including dietary changes and new alternative agents that may be used for managing metabolic acidosis. And so I'd like to start here with the framework. We can look at where KDIGO guidelines stand in the role of bicarb treatment and alkali therapy. As you see here, baking soda has KDIGO's stamp of approval, and their recommendation stands that people with CKD and serum bicarb less than 22 should be treated with bicarbonate to achieve a normal range unless contraindicated. And so strictly, the guidelines recommend sodium bicarb is recommended only for patients with metabolic acidosis defined by this parameter. So understanding the role of the benefits of bicarbonate, we really need to understand the physiology and acid-base homeostasis. So just broad review, acid accumulation, the kidneys have to account and excrete an acid load of about 50 to 100 milliequivalents that a person receives daily. And this comes primarily through the diet, but also in organic acids that are produced endogenously. The amount of acid load that must be excreted really depends on what the diet involves. So more plant-based diets have more organic bases and citrate that's converted to bicarb, and our overall more basic diet. And then the more common Western diet that we encounter with more animal source proteins have a higher acid load. So depending on what goes into the diet, that will determine the acid load and how much the kidneys have to accommodate with excretion. And how the kidneys manage acid excretion are two main mechanisms. The first on the left is the process of ammoniogenesis. So ammonia is converted and protonated to ammonium, which is then excreted, and bicarb, which is created in the process, is reclaimed in systemic circulation. And this is the majority of acid excretion. There are also buffers of titratable acids, most prominently phosphate dihydrogen phosphates, which also account for acid excretion. And so the ammonium and titratable acids account for total acid excretion, and then incorporating the urinary bicarb that's lost as well, we can calculate the net acid excretion, or NAE. And so changes in urinary ammonia excretion really increase dramatically as compensation for acidosis. We'll be focusing a lot more on ammoniogenesis, as that's more of an adaptive kidney response, and it's more involved in the physiology of acid handling in the context of CKD. So renal ammoniogenesis, what does involve? Where is it? It occurs predominantly at the proximal tubule. Glutamine enters from systemic circulation. It's then metabolized into glutamate and alpha ketoglutarate, and the process forms 2 ammonium and 2 bicarb ions. The ammonium ions are then transported via sodium hydrogen exchanger, NHE3, as well as through parallel transport into the urinary space and excreted. And the bicarb that's generated is reclaimed in systemic circulation. And so you can really think of renal ammoniogenesis just as much about bicarb generation. It's repleting the bicarb that's lost in systemic circulation that's buffering all of the acid load that's received throughout the day. And so there's always this acid balance that the kidneys are managing, matching the daily acid load with a daily acid excretion. And in chronic kidney disease, the kidney's capacity for acid excretion declines. They're unable to match the daily acid load, leading to a positive acid balance and tipping them over into metabolic acidosis. The risk of metabolic acidosis really doesn't increase significantly until the GFR declines to around CKD stage 3, stage 4. On the graphs on the right, you'll see on the ammonium excretion and net acid excretion in different stages of CKD. And so initially in CKD stage 2 and 3, there's some component of compensation. The thought is that there's an increase in per nephron ammoniogenesis that's occurring to compensate for the decrease in kidney acid excretory capacity. But over time, with more renal loss, the compensation of increased ammoniogenesis per nephron cannot keep up, ultimately leading to a net decline in ammonium excretion and a net decline in net acid excretion, which ultimately leads to the development of metabolic acidosis. And so in line with that, the prevalence of metabolic acidosis increases as GFR falls, but it's not very fixed in its decline. There are patients with CKD stage 2 who do develop metabolic acidosis, and there are folks CKD stage 4 who have normal serum bicarb. This data is obtained from the CRIC study with 40,000 patients enrolled and determined the prevalence approximately 7% in CKD stage 2, 13% in CKD stage 3, and 37% CKD stage 4 have a definition of metabolic acidosis with serum bicarb less than 22. And there are a handful of clear detrimental effects of metabolic acidosis that we're well aware of. These include muscle wasting, which is related to increased muscle protein degradation, bone disease, bone buffering as a response to acid excess, and acidosis stimulates osteoclast activity as well. And there's a clear association with decreased bone mineral density and a low serum bicarb in the setting of CKD. There's also a clear association, observational data of mortality. There's not an association clearly with cardiovascular disease, but the thought is that there may be some underlying mechanisms that associate metabolic acidosis with cardiovascular disease, and that may be the underlying explanation for the association of mortality. And then lastly, where we're going to focus more on is the association with progression of kidney disease. So those with metabolic acidosis have a higher propensity to have further decline in GFR. And this association between acidosis and a more rapid decline in GFR has historically been well established. The CRIC study similarly also demonstrated this. 3,600 patients were evaluated for renal events, which were either halving of GFR or development of ESRD. And in a 6-year follow-up, the hazard ratio is about twofold, 2 times more participants with a serum bicarb of less than 22 went on to either have a decline of half of their GFR or progression to ESRD. And so this association of metabolic acidosis and more accelerated decline in GFR, it does raise the question, is metabolic acidosis simply a marker for risk of CKD progression, or does metabolic acidosis itself contribute to CKD progression? And over time, we've understood more of mechanisms that may be underlying, and we have more confidence built that metabolic acidosis does contribute to a decline in GFR, and it does lead to a positive feedback loop as shown on the left. And so this feedback loop can be further elaborated with these mechanisms. Interestingly, a lot of the proposed mechanisms for why metabolic acidosis contributes further decline in GFR are actually compensatory mechanisms that are trying to promote more kidney acid excretion. So with a decline in GFR, there's further acid retention. The first mechanism I'll talk about is increased ammonia accumulation. So with increased per nephron ammoniogenesis, like I discussed earlier, as a compensatory mechanism to keep up with kidney excretory acid capacity, there's an increased accumulation of ammonia in the nephron, in the interstitium. And this actually leads to a mechanism of complement activation, cleavage of C3, and alternate complement pathway activation that then leads to tubular interstitial injury. The second mechanism, there's increased RAS signaling. This is to stimulate more excretion of ammonia, and ultimately increased RAS signaling leads to vasoconstrictive effects related to angiotensin II, leading to tubular interstitial fibrosis, also increased intraglomerular pressure, which contributes to proteinuria. So also another compensatory mechanism with maladaptive effects. And then the third mechanism, which may be one of the most important and least understood, is endothelin I. So endothelin I also assists in excretion of ammonia, and it's upregulated in the setting of acidosis, but it has multiple effects of vasoconstriction predominantly, causing endothelial injury. It causes podocyte effacement, which leads to proteinuria, and also promotes pro-inflammatory factors and activates them, which all leads to a milieu of worsening tubular interstitial injury and progression of CKD. And so taking all these mechanisms in mind, you have to be mindful that in a compensated state, a patient may have all of these mechanisms going on, but a normal serum bicarb. So it does raise the question, could there be a role of not just correcting acidosis, but in treating CKD with reversal of these mechanisms to prevent further kidney injury? And a lot of research is looking more into how that could be done, not just in managing acidosis, but through other pathways. So does alkali therapy in CKD slow the rate of decline in renal function? We'll now focus on the evidence that's shown that bicarb slows the rate of decline in renal function in patients with metabolic acidosis and CKD. So there are numerous randomized controlled trials over the past 10, 15 years that have demonstrated this, that giving sodium bicarb in managing metabolic acidosis slows the progression of kidney disease. This is one of the first and more notable studies in 2009. They had enrolled 130 patients, CKD stage 4, and average serum bicarb of 16 to 20. And then they randomized them to either standard care versus standard care plus sodium bicarb to normalize serum bicarb levels. And in the graph shown at the top, not surprisingly, this is serum bicarb levels. Pretty promptly, serum bicarb levels rise with the administration of sodium bicarbonate. On the graph on the bottom, this is representing creatinine clearance. And at about 18 months into the study, they see a significant difference. In the black line, we're seeing the control group that's developing a decline in GFR. And then in the dashed line, we're seeing the patients receiving the bicarb, and they do have the sustained and preserved GFR. So the control group had a decline of 6 ml per minute, and the experimental group, roughly with the treatment of bicarb, only had a decline of about 1.9. So this study did show pretty significant difference in decline in GFR among patients who had treatment of their underlying metabolic acidosis. And how big of a difference is this? So that study was just one example, but in terms of an aggregate of these randomized control trials, there's still not as much data as we may have liked, but this was a recently published 2019 systemic review and meta-analysis in CJASN that took together 14 of these randomized control trials, 1,400 participants in total, CKD stage 3 through 5. And there was a lot of heterogeneity. The interventions were either oral alkali, like oral sodium bicarb, or dietary changes and reduction in dietary acid intake. And they looked to see what was the difference in terms of decline in GFR in these studies. And I'm sorry, I know the Foster plot has a lot of information, but generally the takeaway is there's pretty clear alignment. About half had significant difference, but generally there was a statistically significant difference in terms of decline in GFR. And so this ultimately amounted to a difference in GFR decline of about 3.3 at end study, and then per year, a difference in GFR decline of about 2.1 between those receiving the intervention and those receiving standard care. The caveat of the systemic review and meta-analysis is that there was a lot of heterogeneity. So the evidence they felt labeled was low moderate, but I think with more studies to come, there would be even more evidence to push us to feel more confident that there is a difference in decline in GFR with treatment and correction of metabolic acidosis. And so the next stage of questions, which a lot more of the research is coming through, is what about patients with normal serum bicarb? Does treating them with sodium bicarbonate potentially slow their decline in GFR, even if their serum bicarb is normal? And this was one of the first studies that really looked into this, a 5-year prospective randomized control study that was performed by Dr. Wesson and his group. It incorporated patients with CKD stage 2 hypertensive nephropathy and relatively preserved GFR average of 75. And unlike the prior studies in the meta-analysis, these patients had a normal serum bicarb. The average was 26, and they were randomized to either receive sodium bicarb, receive sodium chloride, or placebo in this 3-arm study. And after 5 years, the rate of decline of GFR was much lower in those receiving sodium bicarb compared to those receiving placebo and sodium chloride. So again, these patients had normal serum bicarb going in. The intent was not to correct a serum bicarb that was low. The intent was just to give them a dose of serum bicarb daily, watch to see where their kidney function went for 5 years. And this was really considered emerging evidence that alkali therapy may play a role in slowing decline in renal function in patients with CKD, even with a normal serum bicarb. And the study went on and interestingly looked more into a possible underlying mechanism to explain this. And so not only did they look for changes in GFR, but they looked into other markers like urine endothelin I and urine NAG. So endothelin I, like I mentioned earlier, it's a compensatory mechanism. It occurs in CKD-associated acidosis, and it's upregulated, but it has a maladaptive effect of tubular interstitial injury. And then urine NAG is a separate marker to look for evidence of tubular interstitial injury. And both urine endothelin I and urine NAG were significantly lower in those treated with sodium bicarb. So this really raised the support of a theoretical mechanism by which alkali therapy could slow progression of kidney disease, even in CKD patients with normal serum bicarb, there can be maybe downregulation of endothelin I production. And this could theoretically be a mechanism that's modifiable to slow CKD progression. And so this evidence supports this concept, and Dr. Wesson frames it in this terminology of eubicarbonatemic acidosis, or otherwise clinical acidosis or subclinical acidosis, which is essentially this category of patients who have acid accumulation in CKD that's not sufficient enough to manifest as a serum bicarb less than 22, but that can still cause pathologic consequences. And so I kind of tried to demonstrate it in this diagram. You have a normal range above 22 with a component of acid retention and active mechanisms that are compensating for that acid retention that make them have a normal serum bicarb, but have consequences that could lead to CKD progression. And so a lot of the remaining question is there this category of patients that stand to benefit from alkali therapy? They have acid retention, but they have a normal serum bicarb. And we don't know yet, but I think that's where a lot more research will be looking into. And another aspect is how to identify who these patients would be that could benefit from alkali therapy. And one of the more attractive methods would be looking at urine markers for eubicarbonatemic acidosis. So two potential urine markers, one is urine ammonium. So having a low urine ammonium, like mentioned earlier in slides, may suggest that the patient with CKD with a low urine ammonium is kind of teetering on the edge where they're heading towards a positive acid balance, heading towards metabolic acidosis, but not quite there yet. And so they may, if they have a low urine ammonium, but a normal serum bicarb, may stand to benefit from oral alkali therapy. And then urine citrate, having a low urine citrate indicates compensation to avoid base loss and may also be a possible marker to look at. There's some studies looking into utility of a citrate creatinine ratio as a spot urine test to identify patients with underlying acid accumulation. And so are there other alternative strategies to alkali therapy in managing metabolic acidosis? So fortunately, sodium bicarb is very cheap, very well tolerated. It costs about $1 for a pound of baking soda, so that's also an alternative. And there's an equivalence of 1/8 teaspoon for one tablet that can be helpful to tell your patients. But other possible options among alkali therapy are sodium citrate, which is generally slightly more tolerated, less GI side effects. And then potassium citrate formulations. Obviously, potassium is limited in CKD, given risk of hyperkalemia. But I wanted to just draw attention, a lot of concern around sodium bicarbonate comes back to whether sodium triggers worsening fluid retention, peripheral edema, pulmonary edema, and not much evidence really supports it. In all these randomized controlled trials that have investigated sodium bicarb, there hasn't been much of an association at all for fluid retention, but it's still considered because there's 180 milligrams of sodium per each tablet. So there is a new agent now that's being investigated. It's not FDA approved yet, but completed phase 3 trials in the Lancet in 2019 called TRC-101. It's a sodium-free hydrochloric acid binder that binds to protons and chloride ions in the GI tract. And it's shown to be effective in lowering serum bicarb. So far, preliminary data shows it has a relatively safe profile, but in terms of whether it would have much utility, because sodium bicarb is so well tolerated, I don't think that there's too much promise in terms of its need in the future, but it is a novel sodium-free method of managing metabolic acidosis that we may be seeing in the future among CKD patients. And then other alternative strategies, most importantly, dietary changes. So modification of dietary acid reduction definitely demonstrates a management in metabolic acidosis that's comparable to oral alkali therapy. There have been randomized control trials that also show that dietary acid reduction in addition of base producing fruit and vegetables is actually comparable in some trials to the benefit of oral alkali in not only correcting acidosis, but also in managing CKD and reducing decline in GFR. The one thing to be mindful is the potassium content. If you are to be advising patients to increase their fruit and vegetable intake to manage their acidosis, you have to be mindful of the potassium content that comes with that. And so with diet, Dr. Wesson also has formulated this in a recent review in 2021 concept of continuum of acid stress. And so this kind of ties things together as less of a dichotomy of metabolic acidosis as a strict cutoff, but more of a continuum. So on the left, you have a low acid diet, a normal GFR. On the right, you have a higher acid diet and more progressive CKD, a reduced GFR. And ultimately, as you move to the right, plasma bicarb decreases and you reach that threshold of having true metabolic acidosis. But it really is a continuum, and modifying this framework highlights the contribution of high acid diet and also emphasizes that there is injury beyond just the cutoff of serum bicarb less than 22. So this establishes a paradigm shift in which metabolic acidosis CKD is more than just treating a number. And so just to leave you a few take-home points, mechanisms of CKD progression from metabolic acidosis involves compensatory mechanisms, ammonium accumulation, endothelin I production, and RAS signaling. There's moderate evidence that alkali therapy and dietary management in metabolic acidosis can reduce decline in GFR. There's within patients with mild CKD, a cohort of patients potentially with eubicarbonatemic acidosis that may stand to benefit from oral alkali therapy. And reducing dietary acid by adding base producing food components is an effective initial step in decreasing acid accumulation. And with that, I'll open up to questions.
Thanks so much, Eric, and I'll congratulate you on, I think you're the only fellow in recent memory to voluntarily take on an acid-based topic for Grand Round. So nice work. So there's an initial question from Dr. Flynn. In the Wesson study, so what plasma level of bicarbonate was achieved? Did they have a specific goal, or did they just provide supplemental bicarb?
Yeah, in the 5-year prospective study, they just provided plasma. They just provided a sodium bicarb. Going into it, the median serum bicarb was 26, and they were prescribing 0.5 milliequivalents per kilogram per day. But yeah, I didn't see in terms of what levels they were achieving, but I know going in normal serum bicarb, and they just set a standard dose.
So Dr. Hazley asks, how many milliequivalents per kilogram of bicarb do you recommend to slow progression?
So at the moment, I generally, rule of thumb is you start with 650 milligrams BID. If the serum bicarb is less than 18, I would start with that dose off the bat. If the serum bicarb was in a range 19 to 22, I'd likely repeat the serum bicarb again. And then if it's consistently less than 22, then I would start with, again, 650 milligrams twice a day.
But I guess that's incredibly below 0.5 milliequivalents per kilo for most patients. So, I mean, that's just, 15 milliequivalents a day. So, or it's a fourth the dose basically or half, sorry. I just wonder if we just use too little a lot of the time. That's why I'm just asking.
I just want to echo what Leah said. I've been amazed how much bicarb we need to
Yeah.
actually change the serum bicarb levels.
Yeah.
And that's been my experience as well. So you probably need like 50 to 70 milliequivalents a day
Yeah.
in people with bicarbs less than 18.
Well, for RTAs, we're frequently taught that you need like 1 milliequivalent per kilo or even 1.5, depending on the type of RTA, more than that. So I know these people don't have full on RTAs, but do you recommend using so they use 0.5 milliequivalents per kilo in the paper with people at normal bicarb to begin with. Is that right? So
Yeah, that's right. For the Dr. Wesson paper, the prospective study.
right.
I want to chime in if I can. It's really hard to answer these questions. Eric, that was a fabulous talk. And you appropriately couched the conclusions with, moderate and may, because the trials are short-term trials looking at change in eGFR. We don't have pivotal trials for bicarbonate placement. The FDA would never approve bicarbonate for this indication. And we need those trials. We don't know whether higher doses of bicarb, for example, are more beneficial than risk. And so this is very exciting, but the data are not conclusive. And then, we do sometimes apply these trial data, which are mainly in stage 3 patients, to people who have stage 5 CKD, for example. And they have limited ability to get rid of sodium. So the toxicity of sodium may be substantially greater in people, for example, who have heart failure, wouldn't be candidates for the trials in low eGFR. So while it's promising, I think we need to be, as you have been, conservative in how we interpret and apply the data. My 2 cents.
There's a question from Dr. Logar about, in some patients, there's a dissociation between serum bicarb and the blood pH. Is there a role in VBGs in CKD? Thoughts, Eric?
Yeah, I didn't see much mention in terms of the context of eubicarbonatemic acidosis or a role of monitoring VBGs. And I know generally, at least in the literature I was reading, that I'm not sure about KDIGO guidelines, but generally the authors would favor not utilizing VBGs in evaluation of metabolic acidosis and CKD or monitoring the guide therapy. Curious if anyone else has seen otherwise.
All right, well, I think we could probably continue to have a robust discussion. Thanks, Eric. We'll move on now to the next speaker.